for us as urologists and for urologists that will see us, I think it's a very important question. Do you think if some of those patients that actually have this borderline situation, I'm not saying the patient that's clearly metastatic disease, but really that patient that you're not expecting, the PSMA, if they say it could be a reactive lymph node, SUV of 3, 5, 4. Let's say we do surgery for this patient after, of course, share decision making, you have a discussion, and patients say, let's go upfront surgery. You do surgery. And once in a while, you realize that indeed that patient had metastatic disease.
Yeah.
Do you really think that this is like the worst thing that we have done for this patient to have a local treatment as surgery? Because although we don't have prospective data, we do have kind of decent retrospective data showing that maybe this patient benefit of having the radical prostatectomy. You think that, or you really would regret of doing the radical prostatectomy?
It's a great question. Yeah. I mean, it's challenging. A lot of patients, especially younger patients, want to have this kind of full court press mentality where even if there's a node that's positive, they consider surgery up front with radiation to follow. Because there are good studies that show potentially that has a better outcome than just radiation alone. So we offer to patients in that setting, but I tend to be very aggressive up front with staging. And I think urologists in general are doing a better job of knowing exactly what the disease a patient has up front so we can make the best decision forward. Like Gordon said, biopsying these lesions, trying to get the best scans like a PSMA. We're doing such a better job now of knowing a patient's true stage than we used to be 10 years ago.
And maybe this becomes a little bit of a moot point as we see subsequent data, sets reported out. We know if these trials that are in progress report out as positive, and we're routinely giving these folks, neoadjuvant therapy for N-positive disease to give them surgery, for example, maybe we're less concerned around tissue sampling in this scenario because we're going to give them, an ARPI up front, for example,
exactly.
then take them to surgery and give them adjuvant therapy on the backside. So maybe that becomes, hopefully these trials will help us answer some of these, I think, very important and relevant clinical questions for us.
Before going to systemic treatment, let's say now moving not like just this borderline case, but cases that we really think they're metastatic disease, oligometastatic disease. And we're going to do some systemic treatment, most likely some radiation to the primary tumor with standard of care. And then there's this discussion of doing or not some radiation to the metastasis. A couple of bone metastases, one lymph node and retroperitoneum. We know we don't have data for that, but are you guys or your radiation oncologists that work with you guys that really pushing for that? I mean, I have guys really enthusiastic about doing radiation for some like MDT. I'm not talking about recurrence, just primary treatment, doing the prostate. Patient is already going there to the radiation oncology clinic, having the prostate.
So I'm happy to start with that and let everyone else build on it. But I think that was covered in the Extend trial where they gave patients EDT and hormone therapy, ADT and radiation plus ARI, ADT and radiation. And there was a benefit to that treatment intensification with as well as treating those oligometastatic sites. So if you're looking at trying to hit them up front, as you mentioned earlier, and then maybe being able to de-intensify patients down the road, like pull some therapy off and let them kind of cruise, maybe get testosterone levels back. I think that's important if they're a younger man, but I think that really harps on to what you mentioned earlier is that that's really where you build that conversation with the patient, what their goals are in the clinic. You're going to, the way I treat at least a 58-year-old guy versus an older gentleman that's maybe like teasing around his young 70s to mid 70s is going to be a little bit different.
So before going to which kind of treatment we're going to use, but go ahead.
So I wanted to add on to that, the Wolverine trial, right? We looked at that as well. I think similar situation. And we do see modest improvements in overall survival, 12%, not great. We saw some delay in PSA progression and delay in time to development of castration resistance in that same patient population with treatment to the metastatic sites plus treatment to the primary. So I think if you have low volume, and what we define as oligometastatic is a little bit different based on which trial you're looking at, whether it's 3 or 5. I think wherever you cut that bar, but certainly nothing that I'm aware of is above 5. So anything that's 5 and less, you may be kind of consistent with. But that also, depending on the location within the skeleton, that could in thery fall into a high risk patient. But that's a different again, a little bit nuanced there. So I think that as we kind of walk through this, I think, at least I'm routinely treating those patients. If they have 3 or fewer oligometastatic sites and their primary, I think we have pretty good data to suggest that there's a benefit there, at least from my perspective.
Okay. And actually, what my radiation oncologists will always say, there's like very few downsides on that.
Yeah,
I mean, there's not much risk on doing the
Yeah.
radiation. It's like short treatment, not a high dose. So it's kind of, I think we're getting more and more like related to this, to this kind of treatment.